Hello and welcome to the Under Pressure podcast. I'm your host, Dr. Jonathan Sackier, and I'm really proud to be here. Before introducing today's guest, it's important to specify that this podcast has been supported by Myo1, a Canadian medical device manufacturer. So please refer to the show notes for further information, and you can be in touch with us at underpressure@nextsense.com. That's underpressure at nxtsens.com to ask any questions that we shall endeavor to answer or for any recommendations you may have. So today, I've got the pleasure and privilege of welcoming a rather dynamic guest whose clinical leadership and technical expertise are changing the shape of future orthopedic trauma care and much more beyond that. And we're going to get into all that. Dr. Hans van Lancker is a fellowship-trained orthopedic trauma surgeon, innovator, and healthcare systems architect. He currently serves as the network chief of all musculoskeletal stuff, basically. He's the network chief for orthopedics, rheumatology, physiatry, and rehab at Cambridge Health Alliance. And he also holds appointments with Harvard Medical School. He's a Castle Connolly top doctor, Harvard Macy Innovation Scholar, and founder of several organizations, including the Boston Orthopedic Trauma Group and the Ortho Capital Partners. What makes Dr. Van Lancker's approach so compelling is his relentless drive. And as I've come to know him a little bit, I've seen that it permeates every aspect of his personality. A relentless drive to implement highly reliable, standardized care with measurable impacts, such as a 150% reduction in length of stay and major operational gains across complex hospital systems. All of us in medicine know that it's easy to talk the talk, but it's not so easy to walk the walk. And Dr. Van Lancker is doing just that. He's also deeply involved in clinical innovation, including AI integration and continuous pressure monitoring in trauma care. When he has free time, and given all he does, it's astonishing to think he does have any free time, his hobbies are refurbishing and restoring cars and boats, specifically Porsches and Land Rovers, and I'm putting an order in for a proper Defender, and classic deep V offshore powerboats. He's also into snowboarding and scuba diving, backyard engineering, and construction. He's currently building a rather sophisticated and elaborate tree house for his kids. I told him that I built one for my kids and took a hell of a long time doing it. I don't think they went in it more than once, but I loved the place. He's designed orthopedic implants. He's advised and invested in a number of varied startups, and to top it all off, he had a spec Miata race car for a while. So it's astonishing and wonderful and great fun to welcome Dr. Hans van Lancker to the Under Pressure podcast. Welcome, Hans.
Thank you, Jonathan. It's great to be here. And thank you for that incredibly detailed and kind introduction.
Well, I think it's always important that people get a sense of who, there's lots of clever people out there, but there are people who live their lives with passion. And it's very apparent that one of my guiding principles, Hans, is we spend a long time dead. So, may as well get the stuff done now. So look, you've had an impressive career so far, and I'm sure there's lots more to come, spanning roles as Chief of Orthopedics, as I mentioned, at Cambridge Health Alliance, and clinical instructor at Harvard. Could you share what initially inspired you to pursue orthopedic trauma and what keeps you passionate about the field today?
Absolutely. So before I went to med school, I studied business and engineering. And those were both things I chose to study in my undergrad with the intention of becoming an orthopedic surgeon. So I was very deliberate in what I picked to study at that point and what I pursued. And really, the reason that appealed to me so much is the reason that orthopedic trauma has appealed to me as well, in that I want to solve problems. And I want to solve problems that are either mechanical problems, engineering problems, orthopedic trauma problems, or operational problems. And I've gotten a lot more into the logistical engineering and the business side recently with, completing my MBA last year and starting to think about how do we make the whole big picture work better. But with ortho trauma, it became pretty clear to me when I was a resident, and I had a great mentor in Dr. Ed Harvey as a resident. And, he really influenced me in choosing trauma because I wanted the variety. I wanted to be the best at my specialty. I wanted to be the best that I could be in orthopedics. And but I didn't want to give up sort of the different levels of complexity, the different surgical approaches, the different responsibilities. And trauma stood out to me as the perfect specialty for me to do that, because every case requires me to be creative and thoughtful and deliberate. And there's a lot of standardization, but I have to be creative every time I'm in the OR, because none of these injuries are the same. And that was exciting. And it's been exciting, and it continues to be exciting. Part of what's leading me to take on more responsibility within the health system and the hospital and try to solve the bigger problems is I recognize that we have a very broken system as a whole, not within our network, but within the whole of care across our country, across the world. The way that we're doing this is not sustainable. And we need to think differently about it, and we need to solve those problems, and I can't let them be. So that's what's pulling me in.
Yeah, I love it. It is a very practical. I mean, I think all surgical specialties are very practical because you see something broken and you want to fix it. And I have this. I've noticed this commonality amongst the people that I talk to on this podcast, and frankly throughout my career. There are those who just come and do their day job and then they go home in the evening. Then there are others who have. I think we're the luckiest people on the planet doing this for a living. I really do. So it's great to see that and to see the smile on your face when you're talking about it. So you've been very active in both clinical and operational innovations, and you've hinted at that. One of your novel incentive programs is the basis for a Harvard Business School business case, right? That's like the nadir when you do that. Tell us about that and about other developments that you're justly proud of, please.
Yeah, absolutely. So we realized early on, at my time at Cambridge Health Alliance, that we had a supply cost problem. And it initially started with not even understanding what our supply costs were. So we partnered with a company that was able to pull that data out of our electronic medical record and make it digestible and actionable. And once I had that, then an idea came to me with how can I get the surgeons to be really engaged and actually take this data and change what they're doing so that they're motivated to maybe make a decision that benefits the overall cost of care and the sustainability of care within our system. And I recognized early on that you can't just ask someone to do that. They have a certain level of comfort with the way that they do things, with the way that they've been trained, with the way that they've become having a relationship with the rep or with the equipment that they use, and you don't want to break those things down, and trying to find a balance where, well, what's the level of comfort with making those changes that's appropriate, and how do we incentivize a surgeon to make a decision that leads us to a point where we're not spending so much on cases. We were in the 10th percentile for cost, so really very high cost, unnecessarily high cost in some cases, but people were doing what they were comfortable with. So we created an incentive program where that difference, that gain that can be realized by changing the decisions around cost, would be shared with the surgeons. And it's been incredibly motivating. And it's not a huge portion of the surgeon's remuneration, but it's enough to make a difference that, when you're in the operating room, do I really need to use this fancy technology, be it a different plate or a different screw type or a different device? Do I need to use that today? Or is this, maybe a case where I don't, and I need to be deliberate about it?
How do you ensure that you're not compromising? Listen, I'm sure all our colleagues are very ethical, but how do you ensure you don't compromise the quality of care?
Well, I think there's a couple different aspects of that are important. One, the incentive can't be that big. It needs to be just enough to matter, right? If you make the incentive too big, it creates this, issue with people making decisions because they're seeing so much benefit on the other side. But there's a point where I think, people are comfortable with making some changes to see a little bit of a benefit. So finding the right number is an important part of that. I also believe that standardization bakes in, and it's not so much that I want people to change what they do, but I want them to standardize across the department so that we can better negotiate with the suppliers
Sure.
so that there's consistency to what gets done, which then allows us to bake in efficiency and lower the cost, as a result. And it's just being open-minded, right? It's just enough sort of benefit to get people to say, you know what, I'll try that other plate and let's see how it goes today. And if it's not so bad, or if it's really pretty good, then maybe I will make a switch because it's a few $100s less and there's no features, to benefit. And we're not talking about making decisions like not doing a surgery. We're talking about, very sort of small tweaks here and there that actually can have pretty substantial financial impacts. But it's one ankle plate versus another ankle plate, which is not a place where quality changes. It's really just a place where it's personal preference.
Right. Okay, well that makes sense. I mean, I've seen similar systems where it's a system-wide thing. What doesn't work in my experience, I was at a hospital, I worked in America for many years, and the administration decided to change the gloves that we used in theater, in the OR. And one of my colleagues, I shan't mention his name, he's a lot bolder than I am. He just stood there opening packets of gloves and dropping them on the floor and said, "Get me my bloody gloves back because these are no good." They were cheaper,
Right.
but that decision had been made extant the surgeon's input.
Right. And that's what you can't do. Exactly.
Get
So you
together
get
as
it.
a team and say, let's look at the cost of care, not
Right.
the cost of the widget. Right? If the
Right.
if the widget is more expensive, but it gets the patient out the hospital sooner, or it leads to a lower chance of morbidity, then it's a simple decision. I'm with you.
And that's where we've wholly embraced something like Mile One,
Yeah. Right.
because the whole cost of care is better.
Yeah.
Absolutely. And it's more efficient and it's more consistent. And,
Yeah.
and we can make a business case. And I've helped build that business case, for the use in our institution of that device specifically. And that there's a way to look at it that is actually the whole way of looking at it, where it lowers the cost of care,
Yeah.
right? But an ankle plate that has the same features as another ankle plate isn't going to do.
I'm totally with you. I've divided my career on both sides of the duck pond, and over here we have an organization called the National Institutes of Healthcare Excellence, or the Death Panel, as some in America choose to call it. It isn't. What it does is it looks at the economic benefit of a given intervention, and it ascribes a quality, which is a well-known health economic parameter, a quality adjusted life year, and says, is this justified on a healthcare system-wide basis? And we're going to come on to talk about compartment pressure, continuous compartment pressure monitoring. And if you look at, and in fact, there was an economic review done over here, there's absolutely no question. Yes, for the individual patient who may be at low risk for having a problem, well, why should we use it? Because we're not great and we sometimes make mistakes. And if we can preclude mistakes, I love your thinking, love it. So we'll circle back to that. You've grown orthopedics musculoskeletal practice immensely, over 60%, with a completely different approach to care delivery. You've hinted at some of it that's more sustainable, a focus on being efficient and consistent, which has led to improvements in care and financial outcomes, which we've just discussed, vastly improving operating room utilization, for instance, and amidst a diverse practice. Tell us about the what and the how about some of these beyond the financial issues we've just discussed.
So I think that growth is attributed to a number of things. One is Cambridge as a city and as a hospital, I felt like really needed an orthopedic department, an orthopedic division that was responsible for the whole city's musculoskeletal problems. And that's what we've built on, right? And we've marketed that, and and as a result, we've also marketed the department and the institution in a way to recruit that's with the vision for growth. So if you want to be part of something that's growing, you want to be part of something that's learning to embrace technology better and integrating it into care, and even taking that a step further, we want to be an institution that incubates technology, right? We're in an incredibly innovative locale in Cambridge, probably one of the most innovative square miles in the world. And our institution should be leading innovation in orthopedics and beyond as a result of where it is. And that's been a big thing for me in how we recruit. That's been something that I want to bring out of the people that we bring in, is be a part of, the future of the way that we're going to do things, because we're relatively small, but that gives us an advantage of being nimble. And we're in a place where we can partner with institutions like MIT and Harvard and understand how to integrate these new technologies in a way to make our lives easier. We were one of the first institutions in the region and even in the country to have an AI scribe. We've had an AI scribe for over a year, which has been an incredible tool. It's really unlocked the ability to be more efficient in clinic, have a more complete documentation of what's been done, et cetera. And seeing things like that and being able to implement them relatively quickly and get feedback and adapt is an incredible asset of the size and the culture of our institution.
Yeah. I'm very familiar with the area. And it is, as you say, got this incredible density of universities. I think probably more per square mile than anywhere else in the world, and more hospital beds probably than maybe even than the Texas Medical Center. So you've implemented what you call highly reliable standardized care at Cambridge Health Alliance. Can you walk us through how you use data, staffing, and process redesign to reduce the length of stay? I've already hinted that by 150%. And what components were the ones that were most critical to that transformation? Because that's a hell of a change.
Yeah, I mean, I would account some of the ability to make the change on the fact that I think we started in a place where we were way behind, right? So, there was a lot of opportunity when I got there. I think the standardization is incredibly powerful in the context of things like arthroplasty care and in trauma care as well. But in joint replacement surgery, consistency is key. So creating consistent preoperative, intraoperative, postoperative models and processes has enabled us to be really efficient with the way that we move people through their joint replacement experience. And that's preoperative education, which is something that we're innovating in right now and working to make that more efficient and more higher quality. And taking that patient through that whole experience and having them understand that actually what's best and what's most sort of evidence-based at this point is that you go home. And it's expectation management, right? If the patient expects that they're going to go home, they then will want to go home. They will be motivated to go home, and it's changing that story. And it's the same thing. If the surgeon expects the patients to go home, they want the patients to go home. And then it's putting the pieces in place to make sure that that happens. What do they need to make sure that they're safe at home? How do we make sure that they get seen by physical therapy? One thing that we did early on was, we had some of the joint replacements were occurring on Fridays. That was a really hard time to get people home that needed a little bit of extra care, right? We may not have all the staff available on a Friday afternoon, and then if they were to stay, they would have trouble being discharged on Saturday because, again, there weren't the resources that they need. So I shifted all the arthroplasties to happen. One of the first things I did was shifted them all to happen at the beginning of the week so that we had all the resources at the beginning of the week to get the patients home. Now we're back to doing so much orthopedic surgery that we're also doing arthroplasty on Friday, but we're all tuned up to get the patients home immediately. So it hasn't had a negative impact. Yeah. But, that was one trick that worked well early on.
Yeah, I mean, it's something that's fascinated me, that if you can look at a system with a little bit more efficiency. There was a great book years ago. I'm blanking on who wrote it, and but the basic premise is if a hospital was an airport, we all bitch and moan about, when you travel, but actually airports are very, very efficient.
The coordination is incredible.
It is. Well, why don't we think the same way and think, okay, we're going to be discharging the patient. One of the most common reasons patients have delay to discharge is they don't have their drugs. And if you're discharging them at the weekend, how can you arrange that? Well, maybe have a pharmacy open in the hospital so you can give them.
And that's exactly what we did. We now have meds to bed, so they get their meds and then they go home with their meds.
Yeah, perfect.
Perfect example. And one thing you just reminded me of another example that I think is really that fits well with this. So one thing I'm working on right now is I want to increase the efficiency in the OR, right? So, depending on the surgery, depending on the day right now, where there's still some variability to turnover time. Well, one thing that we're working to create is an OR traffic controller. So like an air traffic controller, I want to make sure that there's someone whose responsibility it is to have one patient coming in when another one's going out. How do we parallel process as much as we possibly can?
I mean, I know I'm old-fashioned in some regards. By the way, I fly aeroplanes for navigation. Aviation has been my love. In British hospitals, the operating theatre, we have far fewer ORs per hospital than in America. But what they do is they have a pre-anesthetic room, and that is actually next door to the theatre. And as one patient is being rolled out, the crew comes in, cleans. Next patient's already anesthetized, intubated, wheeled in. They don't intubate and anesthetize in the theatre. They do it in another room adjacent, and it dramatically reduces turnover time. I begged a hospital in the States to consider doing it, but it deaf is. So you've emphasized the importance of patient outcomes in driving clinical decision making. I mean, from anyone listening in who's not a doctor, that's like a duh moment. But can you share a moment or a case that had a lasting impact on how you approach this and what you mean by patient-centered care?
So I do a lot of revision orthopedic surgery, a lot of revision orthopedic trauma surgery. So I've created a reputation for myself and someone who's, I like to think I'm always willing to help. And I think there are lots of complexities that can happen in orthopedic trauma surgery, and it can be tough sometimes, especially when it gets done, in the community without the resources that we're used to having or the infrastructure to support it. But sometimes it just needs to get done, and the outcomes can be kind of less than hoped for. One thing that in taking on those tough cases, they require a lot of care coordination, right? And they may require coordination day of, they may require coordination in advance. One thing I have done to sort of create a nice structure to that within our institution is sort of this daily phone call between all of the surgeons within the hospital. Just talk about kind of whatever's pending. So it could be whatever came in last night, whatever someone needs some perspective on, but getting everybody together to share information, I think, can be incredibly powerful. And it's this opportunity for, sometimes the phone call only lasts a couple minutes, sometimes it lasts 10, 15 minutes, but we do it first thing in the morning and we just talk about what's going on today so that we can coordinate the care as best we possibly can to be as efficient as we can with the orthopedic trauma cases that came in the night before or complex cases that might be on deck for today that someone might want perspective on. But creating that space has been so powerful because people know that if they show up, there will be someone there to talk through their problem with, and we will together figure out whatever's best for this patient. And I think it's been really great for the patients and in this opportunity to advocate for them to get what they need right now. At the same time, I think it's given our department this place where everyone feels that they're supported and that they can come with a problem and together we'll figure it out. And that's every day. So, that's one simple thing that I feel like has gone a long way. And it's been a great learning opportunity, I think, for a lot of us too, right? It's where we can share things that worked for us, that didn't work for us. And, and we take that to the next level with a Q&A rounds and, we go deeper dives on a lot of things, but that daily space is really important.
Yeah, it's great. How many people in the group are doing that?
Usually on that phone call, every morning there's somewhere around 20, 25 people. So, and, I think there's probably over 40 invited, but, every day we'll get, and it's great. So,
It sounds like,
and it gets, for me, it gets we know what we need to do and then we can act on it and get it done.
yeah. But just the very thought, Fred or Jennifer, I've got a patient coming in, and I seem to recall you had an issue with would you mind sticking your head into theatre, into the OR, and giving me your perspective? I think it's a great idea. Love it. Love it.
Exactly.
It's collaborative. In a recent talk, Hans, you mentioned the concept of medicine evolving from an art to a science. Some of the books behind me are history of medicine books, and I love all that stuff. Can you elaborate on what that perspective is, and how this mindset shift can impact operating room workflow, outcome predictability, and in fact your total approach to patient care, art to science?
Absolutely. And for me, science is when we've sort of proven what was an art until it was a science, right? So we've taken something that we've been doing and we've done it enough to know that it's consistent, it's reproducible, and then it becomes a proven science. And it's that technique is no longer sort of there will still always be art to some of what we do with orthopedic trauma surgery, potentially always, but at least for the foreseeable future. But there's a science to a lot of it in my mind, that there's a best practice of how I need to maybe surgically approach this fracture, what type of fixation I would need for a fracture type. Those things become very consistent, right? And when you can start to create standard processes that are reproducible for those problems, your outcomes become more and more consistent, right? And like with compartment syndrome, having a consistent approach to how you're going to diagnose it and treat it leads to a better, more consistent outcome. And that's becoming a science, right? Compartment syndrome before, I think is a great example, was an art. It was like I had to see enough of it to know what I was looking at and be like, no, this is, or yes, this is compartment syndrome. But now we're getting to a point where there's a reproducible, data-driven tool to help make a decision. So that's getting more in the perspective of science as opposed to an art. And that's where I think we're going, right? And seeing those things as they happen and then creating the structure to be able to implement them is huge.
And the ability to take data from our colleagues in our hospital, in our city, around the world, and say, this is what the data shows, and believing it, because there's still there's evidence-based medicine, but I've got my own experience to guide my decision making. You're a very tech-forward kind of a chap, and you've already mentioned being the first in Boston area to use AI scribes. And we're going to dig into compartment syndrome a bit more in a second, but can you tell us a bit about your philosophy to embrace new technologies? You've already hinted at it, but I'd like to dig in and find out what drives your brain to have that approach, because a lot of people are not. They're very, very, they're sort of bound up. This is the way I do it. This is the way I've always done it. I'm damned if I'm changing.
So I'm looking at new technology all the time. And there are a few questions that I always ask of it, and I ask myself of it, in trying to decide whether or not it's something I want to look further into. And one, I first want to understand what problem is this technology aiming to solve, and is that a real problem? Am I feeling that problem? Or maybe sometimes I'm not feeling it and I didn't even know I had it, but there is actually a problem that this aims to solve. And sometimes with some technologies, there really isn't a problem to solve. And that's sort of a good first step to sort of filter out the ones that might fit into that cohort. And then the second question I have is, does this technology help my patient? Or does it help me? Or does it do both? Right? And I think that those can be exclusive. They can be inclusive. There's variability there. But if it just helps me, we're going to need to make sure it doesn't hurt my patient, right? And with AI, the thing that I think about a lot right now is, there's two different places that AI fits right now. There's the clinical application, where I think for me right now, if you're using AI to make a clinical decision, there has to be a human in the loop. So with the AI scribe, it could affect the clinical documentation and what gets done. So I have to read that note and sign off of it. I am the human in the loop in in that scenario. So that's important for me right now with the clinical applications of AI. So, is AI ready to go make clinical decisions independently? And no, I don't think it is. I think it needs a human in the loop right now. It could get to that point, but I would want to see a lot of data that it doesn't continue to need that cross-check from a human. In addition, there's other aspects of AI where it doesn't have any clinical application, right? That we can use it to mine, potentially mine data that actually requires a human in the loop. So that can be a little bit of a gray area, and that if that data then could lead to clinical decision making, I need to make sure I get all the data. So there has to be a reliability to the data that it pulls out and then gives me. So that's one part. But there are places where it likely doesn't have any effect on the actual care of the patient. And I think those places are great, right? So if it could be, triaging certain things, or, compartmentalizing things into certain groups that otherwise would have to be done by someone specifically, and then, then passed on to someone else. I think those are good opportunities. So, those are the important parts of when I'm assessing a new technology. And if it kind of, and then what's the cost, right? So does it financially make sense? And that's building a business plan. That's part of where, I get very interested in that, because I want to find both a clinical, operational, technical solution that is also financially sustainable, because otherwise, what's the point, right?
Let's dig into compartment syndrome. You've talked about protocolizing care pathways for conditions like compartment syndrome, and the subjectivity of, is this compartment syndrome, is it not? When I first got involved in this, although I'm not an orthopod, I've certainly done enough orthopedics in my time and seen enough multi-trauma, and I've also seen patients who've had abdominal compartment syndrome, or patients who've developed a compartment syndrome in their leg as part of a major operation. And it's always seemed arbitrary to me, is it, isn't it? And as someone who's very pedantic and pragmatic, I like numbers, right? I like a protocol. So talk to me about the protocolization of the evaluation of compartment syndrome, and why this continuous pressure monitoring technology tickled your fancy.
So where we can standardize things and have consistency and data to drive our decisions, I love that. I'm just like you, and what you said, and that, if I can make a data-driven decision that I can get a reproducible outcome with, that's obviously more appealing than one where I don't have those resources and I don't have that information. And with the Mile 1 device, I have data now that I never had before. So I would get a single instance of data from a single compartment with a striker needle, and I would need to make a decision based on that. But so much of that decision would be based on sort of where things were in the spectrum of the patient's clinical response. And then that would be very complicated by, have they had, narcotic pain medication? Are they narcotic naive? Are they, do they have another contributing injury? Do they have a head injury? What are the other aspects of this that are changing the way I interpret this data, and not being able to trend it, made it hard to make that decision sometimes. And you would see that in the literature, you'd see it in stories from other places, where things weren't necessarily what you thought they were, and how that can lead to a negative outcome. So how do we eliminate the potential for a negative outcome? Because the negative outcome is not only bad for the patient, but it's also very expensive. And those are things that we want to avoid. And building a plan around how to use the device, the Mile 1 device, in a reproducible way, lets us avoid those really bad, complex, poor outcome situations. In addition, there's an enormous variability to the surgeon that's on call, their level of comfort with compartment syndrome. So we're not all orthopedic trauma surgeons, and we should never have the expectation that everyone feels the same way about compartment syndrome, or every PA that may be on, or resident that may be on, also feels comfortable with compartment syndrome. So how do we take out that level of discomfort and variability, and get some reproducible, consistent data to make a decision about what needs to be done. There's no question in my mind that all the surgeons are capable of caring for compartment syndrome in a surgical capacity, but there can be a variable level of discomfort with making the diagnosis because maybe they haven't seen it as much. I mean, I'm sure they haven't seen it as much as an orthopedic trauma surgeon has seen it, right? It's, you spend years dealing with these types of injuries. You're going to feel more comfortable when they roll in. But so putting this tool in place where you can say yes or no, depending on what it's doing, is incredibly powerful. One, it creates a level of comfort with making the decision to go for the surgery. That's the right decision. It also puts upon, that surgeon confidence in them to communicate a decision not to do surgery to the medicine team, to the ED physician who's pushing for a further assessment. Well, we've done the further assessment. It's clearly not compartment syndrome, so you don't have to worry. We'll keep an eye on it. We'll monitor it for the next 18 hours, but we know we're making the right decision right now. And I think those that goes a long way for creating collaboration, communication, confidence in the care that's being provided, and that's really powerful.
Could you talk a little bit, Hans, about how you have deployed it, given that the staffing model in the hospital can be different at different times of the day? And one of the things that struck me about this is you don't have to rely on the subjectivity of 4 different people reporting back to you on what they've seen. So number one, there's the variability. Secondly, well, first of all, how have you deployed it? How have you dealt with variability? And have you had any friction points in deploying it? And if so, what were they and how did you deal with them?
So the initial friction point was cost, right? So that's, and that was before we had built what we now have with the standardized protocol for caring for compartment syndrome that incorporates the Mile 1 device. But the initial cost was more than the sort of standard care that existed before Mile 1, right? With a striker needle, it was more money. And it's gotten closer and closer and closer to being nearly the same, which is a huge advantage. But it required me at that point to build a plan that showed the potential benefit of using this as opposed to a striker needle downstream with regard to cost savings and avoidance of increased cost of care. So that was an important initial piece. And then once that was made clear that, wow, we just avoid one of these cases, it's incredibly powerful from a cost perspective, this makes sense, right? So that gets it through the value analysis committee, makes it clear that it's better for patients and, really that's the direction that we should go. And after that, the adoption piece with the surgeons was actually relatively simple because they wanted to use it. It was so much better from an implementation perspective with the data that it provided and the actual ergonomics of doing it, that wasn't a difficult thing to have happen. Then we've created a protocol that's continually evolving, right? So understanding better and better where we should be monitoring, I think is a piece of this that continues to grow with time, right? So initially, obviously, any instance where you're worried about compartment syndrome, just implant the device and then make decisions based on the data that you receive. And that's pretty simple. With regard to the implementation of it sort of prophylactically, that's where things are continuing to evolve, right? So are there certain fracture types that, for me, there have been, and that's, educating across the spectrum of the surgeons that take care of those things. There have been fractures that really we should just monitor every time. And part of the rationale there can be, well, maybe we can provide better pain control with a nerve block, and we wouldn't have been able to do that before because now we can monitor the compartment. I'm not worried about compartment syndrome because I have a reproducible, consistent means of understanding if they have compartment syndrome that has nothing to do with their pain. So, I think those are the kinds of things that we need to do next, right? And that becomes, and then there's values associated with better patient experience, better quality of care, easier to go home because they don't require narcotic pain medication. So I think continuing to explore those opportunities is a really important part of evolving these standard protocols. They can't be standard and static. They need to be standard and continually evolving. So we have a system in our department where we create any standardized protocol, be it for compartment syndrome or hip arthroplasty education. It gets reviewed on a biannual basis so that we know that there isn't something that we need to change.
What has it done to your stimulus to do a fasciotomy? Have you noticed a change in the number of fasciotomies, the number of negative fasciotomies, earlier fasciotomies where there was a compartment syndrome?
I would say that it's made the decision to do a fasciotomy much more consistent, and our level of confidence with doing the fasciotomy being the right thing to do, it's very clear, right? When you see the pressure going up over a certain period of time, you know that this needs something done, which I think is allowing us to get to things earlier. So that's really good for muscle viability and,
Sure.
the patient outcome. I've been able to close things more primarily as a result. So they'll have very well defined compartment syndrome, but I get to them earlier, they calm down faster. You do a primary closure without a skin graft. So from a cosmetic perspective and from a cost
And a cost
perspective,
perspective, and
there's a real benefit there,
yeah,
right? Like that's not a right.
yeah,
It's a whole
absolutely.
nother procedure.
Yeah. So this is again a question of putting together a standardized protocol, understanding what your endpoints are, and then seeing them and seeing them be achieved, and saying, yeah, okay, this is a positive advance in the quality of care. Um, what have you seen in terms of reduced lengths of stay? And you've mentioned not doing skin grafts. Are you documenting that? Will you be publishing anything anytime soon?
There's a lot of things that I want to publish. And as you mentioned, there never seems to be enough hours in the day.
Yeah.
But so I think there's definitely there are things worth publishing there. I think worth examining further. We've definitely seen that those patients don't need to stay in house as long. We've become, what part of what's led to our decreased length of stay being so considerable is we've really swung hard in the other direction, which is great. And culturally, the institution has swung hard in the other direction. So if there's the potential to get someone home and bring them back in for what they might need, we're doing that already, right? So once I know they're stable and they don't need to sit in a hospital bed for any reason, we will work to get them home. And that's coordinating. I mean, that may be that the person that has a fasciotomy gets a wound vac and then has a planned surgery a week later for definitive closure, and doesn't sit in house for that week waiting for that, but they have, a sterile vac dressing on that gets checked periodically, and they come back for closure once things are ready. They come back for a check-in clinic and then they come back for closure. So I think there's all kinds of opportunities to think differently about how we take care of these patients. And sitting in a bed isn't good for anybody.
Yeah.
Even if they need more work,
Yeah, yeah,
let them go home.
absolutely. And your observation about dealing with pain, um, to me, I say to anyone who's had a broken bone in their leg, it hurts, and all you care about is it stops hurting. And someone saying, "Yeah, well, we've
Absolutely.
got to allow it to continue to hurt just in case you develop a compartment syndrome." To me, that was like the aha moment. So I want to switch tack as
Absolutely.
we dial towards the end of this, Hans. You're quite active on LinkedIn. You regularly share insights on orthopedic care and leadership. What do you think about platforms like LinkedIn in regards to advancing medical education, fostering collaboration? There's so much terrible stuff on social media. I commend you for doing responsible stuff, but yeah, what role do you think it plays?
I mean, I think, social media for me is a tool, right? It can be a tool to stay in touch with people. It can be a tool to communicate certain things. Um, but I think that it can be dangerous as a tool as well, right? I think it can be a means for miscommunication. I think you have to be, and it can be a mean which, kind of can be detrimental to anyone involved. The sort of the misperception of what gets said is a really, difficult thing to deal with. The the use of social media to perpetuate things that aren't necessarily evidence-based, I think, is another, complexity that we have to work around and always be aware of. But overall, I've found LinkedIn to be beneficial. I've found, I've made a lot of high quality connections and friendships, even as a result of the communications that I've had on there. I think, my advice with it is don't get too sucked in, but if there's a way to find like-minded people or communicate something that you think you're really passionate about or that's really important, it can be a good conduit for that. But always do it with a little air of, reserve. And I've felt the same way sort of about every part of social media, right? And as someone who has 3 little kids, I think about it a lot. I think about, wanting to make sure that the right balance is struck with the use of these tools, right? I think, and what I like to see in social media is, and in the relationships that I've cultivated as a result of mostly the interactions I've had on LinkedIn, is that the best ones are the ones that, I got an idea about somebody, but then I actually talked to them and the idea that I had about them was actually true. And it was validated in the true human interaction that I had, as opposed to just what was presented on social media. And I've had the opposite happen too,
Yes.
where, it's not the same, right? And that's what I think is important to be cognizant of, because there are people that is the focus, is what's happening there. And for me, that's not the focus. It can be a good conduit to communicate about what's happening in real life that I'm passionate about, that I'm interested in. And that's why it waxes and wanes. To be honest, I haven't had an opportunity to spend a lot of time posting anything lately, because I've been so focused on actually working to solve the problems that are in front of me that it's gone sort of on the back burner, right? And that's how it works for me.
Yeah, I know there are friends of mine, who are very disciplined about posting with regularity about what they're up to. There's a mate of mine who's a very prominent and very successful musician who doesn't post anything. And he says, I can't believe, he says, that people are interested if I'm having a cup of coffee. He said, it's just, he said, if I release a new song, I'll stick that up. But just, I must admit, I think a lot of it is antisocial, but LinkedIn and these kind of professional platforms do allow for engagement and collaborations. And I commend you for that. So you mentioned being busy with solving problems. Looking ahead, what innovations in trauma care, including those you're working on, do you think are going to have the biggest impact on improving patient outcomes and system efficiency? And you're 100% correct. The way we're doing things in medicine doesn't matter whether it's in Britain, America, anywhere. It's unsustainable. We have to get better. We have to get more creative. So yeah, what's got the good doctor excited?
So when I look at trauma care specifically and orthopedic care, it tends to be a part of a hospital system that if done right can be sustaining to the other parts of the health system that aren't as sustainable on their own, right? So that's one thing that we've shown, is that with the growth that we've had and with the improved efficiency and consistency and lowering the costs, we've been able to really contribute to the sustainability of the whole health system, which is, feels like you're doing a lot of good when you're not just fixing the people that are in front of you, but you're facilitating a financial situation for a health system that allows other people to get care. And that for me is sort of the beginning of things, in the sense that community hospitals are an essential thing in our societies, right? We can't have everything filtered down to the academic medical center. It's not close enough. It's not convenient. It's not. But we need to be really thoughtful about what we do in the community to make sure that it's self-sustaining. And that isn't just blanket growth, because there's good growth and there's bad growth and there's sustainable growth. We need to be thoughtful about what we do on a very sort of specific, in a very specific way, and that there are certain cases that considerably benefit to the margin of things that we have to do in the community. There are cases that won't, but we have to do them in the community. There are cases that maybe we should try to do more of, and we should understand what those are. We should understand the contribution margin of each of the individual pieces of the work that we do, so that we can grow in the right way, so that we can grow and be sustainable. That's sort of the first piece, right? Is understanding what you're doing and how it affects you on the whole. And then, beyond that, we need to think about, are there better ways to administer insurance, right? The insurance system, is really an issue across, the United States and beyond. Are there different ways we can think about taking risk as an institution, as employers? What are some different models that might fit with a health system that's been, designed to be a little bit more financially sustainable, right? So I think unlocking the first piece leads you to then think about the second piece. And then it's technology, right? It's how can we use technology all over the place in a thoughtful way that improves the efficiency, the quality of life of the physicians, because we have a physician shortage, and it's not particularly well advertised. But you asked me a question about growth earlier on. You should not have trouble being busy as a doctor. If you bring the right physicians in and you create the culture and the situation for them to do what they're passionate about, they will be busy. That's exactly how we've become busy, to the point that we have no more OR time. We've filled it all up, and now we have to figure out how to grow external to the walls that we were initially constrained to. And there are ways to do that. If you're creative, there are ways to still grow, even when you've used all of your infrastructure. Because somebody else hasn't used all of their infrastructure. That's ultimately what it is. But I think that, thinking about the ways that we can make an environment where people can thrive and do more with less time, with less energy, energy used on things that they're not passionate about or that don't provide, real job satisfaction. I think, and it's not just the physicians, it's the whole spectrum of who works in the hospital, right? I want everyone working at the top of their license. I want everyone to be excited about what they're doing, because we've figured out how to take away all the work that you don't want to do with technology, with sort of better use of the resources, et cetera.
Bang on target. And having spent half my life in America and listened to Americans decrying socialized medicine as it's described, I've never known what that meant. It's a single payer system. There's one insurance company, if you will.
Right.
And then I hear my British colleagues banging on about the American for-profit. I know for a fact that there are great doctors and great nurses and great OTs and every other healthcare professional and great hospitals on both sides of the Atlantic and all around the world where there are good people trying to do good things. And I wish that we could actually look at each other's systems and say, you do that very, very well. We should adopt that. So as we go to the closer, Hans, our audience includes trauma professionals, surgeons, healthcare innovators, a wide range of people. What's one message you'd like to give them in general from this conversation about improving trauma care, one, and secondly, deploying continuous pressure monitoring for compartment syndrome as an example of how technology can make care better?
That's a great question. The one thing that I continually do that I think I wish more people did was I just question the way that I'm doing things all the time. And I use technology sometimes or what's happening in technology to ask myself if it's something that I should question. But it leads me to find all kinds of different solutions, be it from my experience and interests in cars and boats and technology and mechanics. Maybe there's something there. Like, why am I doing this way? Do I need to do it this way? Is there some other industry that has the same problem that's figured out a better way to do it? What can I learn from that? What can I use? Is it a tool? Is it an approach? And I think as an approach to solving a problem, and that's where, I think the business education piece has been really fun, because that's a lot of what you learn is this company had this problem, it's a totally different company, but this is how they solve this problem. That can lead you to figure out a way to solve a problem in another completely different organization, completely different industry. We need to do more of that. We need to ask more of our colleagues, right? I need to talk to more general surgeons about how they're solving problems. Talk to more surgeons in other countries. I mean, I think what you mentioned earlier about the pre-anesthetic room, it's funny because I was working with another hospital to think about how they're going to redesign their operating room. And one of the things that came up was, what if there was a place to prep the patient before they went into the operating room? Do we have enough space to do that? Because it would increase the efficiency so much, right? Exactly like you said it. And why aren't they doing it here? It's one of these questions, right? And, I had been exposed to that elsewhere, and you've affirmed it again, but that's an incredible opportunity to think, well, if we're going to start over in how you design this, what is everything we can do to make it work better? And I want, instead of sort of going through training, learning how to do things one way and sort of sticking with it because you're comfortable, I wish more of us would just push and say, maybe we don't have to do it that way. It's okay to change what you do. I've changed what I do in my practice so many times, and it's always been, after I've validated and confirmed that it's better for my patients, I make a change, and then I stick with that until something else comes along. And the Mile 1 device is a perfect example of that. Right? I had a protocol before we had that device, how I was going to make a decision about compartment syndrome. It was more an art. It was more, I need to think about what I'm seeing here. I need to do these clinical examination tests that maybe I can teach to someone, but I need to do these things consistently to put that data together to make a decision, right? And that data wasn't as reliable, wasn't as consistent. It was highly dependent on me having a look at things to make it consistent. We can get away from that now. We can build a future where we have real data. And it's the same thing that we've done with supply costs and OR utilization. You have to find the data. Once you have the data, then you have to start making decisions and be consistent and use the data that you trust to make those decisions. Yeah. And that's where any opportunity that you have to find more data, like with the Mile 1 device, take it and then figure out what you want to do with it.
I'm totally with you. I'll finish with an aviation perspective. They say that, and I've been flying a long time, they say that, a good landing is one that you walk away from. A great landing is one where you get to use the airplane again. But the proudest comment I think I ever made, someone asked me, who was just learning to fly, and said, "Jonathan, how do you know when you've made a really great landing?" And I've been flying for decades. And I said, "When I've made one, I'll tell you, because you can always do it better. You can always learn."
Absolutely.
Always learn, always. And I love the idea of your daily telephone call. I think that's brilliant. I think it's brilliant. Just an attitude of stop us being siloed. Let's become a team. Let's evaluate what are our colleagues. They may have a problem I can help with. I may have a problem they can help with. Let's try and do things better. Dr. Hans van Lancker, you're an amazing bloke. And I wish we could get together and have a beer, because I think there'd be so many other things I'd love to talk to you about, including that Range Rover long defender and having some fun with that. Thank you so much for being on the podcast, and frankly, for everything you're doing to improve patient care. And if I happen to suffer major orthopedic trauma, I hope it's within striking distance of where you're working. Thank you, sir.
Thank you. It's been great. Thanks so much.
So to the audience listening in, thanks so much for taking time out of your busy day to demonstrate a desire to see, to find the best care for your patients. Please share this with your colleagues, your friends, post on social media, responsibly, of course, and write to us with comments, questions, or requests for other podcasts, the other topics you'd like us to cover at underpressure@nextsense.com, underpressure@nxtsens.com. We'll also put that in the show notes. Thanks also to Maya One for supporting this podcast. And all that remains for me to do, Jonathan Sackier, is to say, please everyone stay safe, stay well, stay curious. Bye for now.